So I'm going to ask all of the morning speakers to come up. We're going to have time for some Q&A with our panel. So if you can have a seat over on our left-hand side, my left-hand side here. And then just as a reminder, there are note cards at the center of the table. So if you have specific questions that you want to ask, you can write them down. We have some people circulating that will collect those cards, and then we can pose those to the panel. While all of that is going on, I'd like to introduce Matt Lorincz. He is going to moderate the panel session. He is an associate professor of neurology here at the University of Michigan, as well as director of Michigan Neurosport, and then the research core director for the Michigan Concussion Center. So welcome, Matt, and we will have some questions.
Thanks, Steve. Appreciate that. I also wanted to make a reminder to those viewing on the webcast that if you have any questions, you can send them to the designated email, that's uofmconcussion@mich.edu, and the staff members will transmit those questions to me. So far, I don't have any questions that I'm aware of coming from the audience. Here are some cards. So as those comes up, I'll just kind of take a opportunity, sorry, we're kind of at an acute angle here, but to ask a question and then look through. I just want to get the kind of the expertise of the panel, because we've heard a lot about a lot of symptoms this morning, about what can happen with concussion, and then tools that we can use. And I wanted to hear from the experts, like which of these things when you see an acute concussion, do you really rely on, both with acute management and diagnosis, and then when returning to play? So if some comments on that, I'd appreciate it.
Well, I think one of the things is different providers for concussion are really interacting with the concussed individuals at different time points. So what you might use in an emergency room setting or a sideline setting might be quite different than, for example, what I would typically use, which is a week or two later when they're having persistent symptoms. So in our persistent symptoms setting, we do use still some of the SCAT tools, with the understanding that using the symptom checklists to follow symptoms is not the same as using them to diagnose. The sensitivity of SCAT for diagnosing is gone within 3 or 4 days. So outside of the acute setting, you use those tools, but you should understand you're using them for a different reason. Often we'll find that using balance or cognition or eye tracking or other subtle measures can help us with an athlete who may be overeager to return to play and maybe can pass sort of some screening exam, but you find, oh, they're a little bit off with their balance or a little bit off with their cognition or visual tracking. So you can use some of these tools in a different way with athletes who are, maybe minimizing symptoms or other things when you want to try to avoid only subjective measures. I think in the acute setting, I don't know if maybe it's better for you to talk a little bit about, like on the sideline, using the SCAT right up front is really the validated use of that tool.
Yeah, for us, certainly the concussion symptom scale is valuable. As I said, the SAC, we've relied on that for a long time. I mean, we don't necessarily have a given number that, if they fall this far off their baseline or anything like that, but it comes a little bit of a clinical judgment just in terms of, again, reading the presentation and the responses and those types of things, and using some balance assessment as well. So it's using all of those tools, and then for us too, a team approach as well, not necessarily just the reading and interpretation of one individual, but advantaging the multiple professionals that we have there, and making sure that everybody's seeing the same thing or bringing all the thoughts and opinions to the table as well.
I might add one thing here also, and it gets to actually some of the things that Blaine talked about. And it's not necessarily a validated tool, but it's increasingly available and useful, is a video of the event. And, anecdotally, I had a faculty member colleague whose child had potentially gotten a concussion playing volleyball, and they were, pretty much minimizing it. They said, probably not likely. Volleyball is a low-risk sport. I didn't think there was much of a risk either. And we kind of jokingly said, well, who had a video? And they actually had a video. And what you can see is the ball was spiked into the player's head who wasn't suspecting it, and their head whipped, and then they fell to the ground, and their head hit the ground. And having that video helped me to, prioritize that patient to come in more urgently to see us and to have a higher level of suspicion that a concussion could have occurred in what's otherwise kind of a low-risk sport. And surprisingly, an increasing number of youth athletes, even though they don't have all the sophistication of a collegiate team, but because of handheld phones and stuff like that, you do sometimes have access to a video, which can be pretty helpful if you ask for it.
And again, for us, and we did a study, and it just came back video, and we're blessed in our situation. We've got multiple cameras and we've got replays and those types of things. But even before we implemented that, at least at our level, a lot of competitions are on television. We would have individuals sitting at home with their HD TV and their ability to rewind and, hey, you see something, call us and let us know. So just some simple resources like that. And again, everything's on camera at some point in time in this day and age. Somebody's got video, so at some point in time availing that. But again, there really hasn't been a situation, a circumstance where we saw something that we didn't already see, but it certainly helps us confirm what we think we know.
Kind of in a related topic, and with sort of the use of our handheld devices, any comments on use of apps for diagnosing concussion or perhaps even following concussion?
Yeah, at the University of Pennsylvania, not as part of the Ivy League Big Ten epidemiology of concussion study, but in other work that we do, we've developed an app. We call it Recoups, Recovering Concussion Update on the Prevention of Symptoms. We did that first. It stuck. It's staying that way. And that's an app and a protocol that we've used in a couple of different contexts. First, in sports medicine at the Children's Hospital of Philadelphia, led by Tina Master in sports medicine and Mike Nance, trauma surgeon, who saw kids at baseline and saw them quite consistently 2 weeks later at clinic. And the good news was that most had symptoms resolved by then. But they had no idea at what point the symptoms resolved, had no idea what the kids had done in terms of physical activity, cognitive activity, and no idea whether all of these were related. And so we developed an app, enrolled kids as research participants also at baseline, and they were highly compliant and got pinged multiple times a day to fill out the scat on the fly. How are you feeling right now? A disadvantage of waiting 2 weeks and then asking for recall for that is poor. We also were measuring step count with a Fitbit, validated by a cell phone if they were wearing it, and also asked about cognitive activity with 8 questions, and at the end of the day asked, and also tracked sleep with a Fitbit. And in doing that, we really had moment-by-moment information on progression of symptoms, and in particular, we were able to start looking at, as symptoms came down, did kids start to get more physically active, for example? When they did that, did they pay for it and get more symptomatic, or did symptoms come down faster? And that continues. We're now enrolling kids out of the emergency department at CHOP, emergency department at HUP, and as I mentioned before, also with John Letty in a trial where they're using this protocol to monitor their athletes who are put on a treadmill. And send daily reports to the provider to identify, in particular, adverse events. So that's where we're evaluating progress. Not clinically validated, but very useful for gaining information that the providers are finding useful and that are helping us with further epidemiologic analyses.
Anyone else use any apps? It's obviously kind of a controversial topic, and there's, I think, a lot of apps being sold and marketed. So just, I would say, for my own advice, be careful with them right now. One of the other questions we had sort of related in terms of documentation. I don't know if the experts have a recommendation on an injury surveillance system that some of the athletic trainers in the room could use, that they would have a recommendation for the best one that people have had success with.
Do you want to promote yours first, or?
Go ahead. With the Ivy League Big Ten epidemiology of concussion study, there's been just terrific buy-in across institutions where, surveillance is already happening. athletes sustaining a concussion are identified, data are being collected for clinical purposes, and we've simply put the infrastructure in place and got buy-in to further take those data and bring them in and use them not just for clinical management, but as information to conduct analyses. We do that with informed consent at the beginning of the athletic season. And that's a very large surveillance system that's been active for 6 years now across 2 athletic conferences. And it's going well, but it takes sustained effort and it takes support. And that endeavor is quite modestly funded. And we want to bring more research dollars to this to make sure that the infrastructure is robust. These are athletic trainers who are tasked with recruitment and data collection, who have primary hats in other fields clinically, and we want to be able to better support and include researchers to work with the athletic trainers to relieve them of some of those responsibilities where we can.
Yeah, thank you. I didn't really want to advertise or talk about one surveillance system over another because each of them has their strengths and limitations. I think the most important thing for anyone working in the field is to consider letting some of their data collected be part of that surveillance effort. So making sure that the data is not only going to help their own institution, but it's also going to help others who may not have the resources or the availability to actually collect the data. At the end of the day, though, surveillance can be as easy as just getting an Excel sheet and utilizing the rows to be each individual injury and each column being something similar to what we see with the surveillance systems and the data that are available in the academic journals, such as who the athlete is, what sport they were playing, what was the injury site, what was the mechanism of injury, things that, technically speaking, should be collected as part of daily clinical practice. But the benefit of having that data collected is that at some point you can go back to your administrator, you can go back to your athletic director and say, look how much work we're doing, look how many injuries we're collecting, and look at these trends in injury incidents. And maybe that can help you advocate for additional care, for additional resources. I've heard many success stories of individuals just capturing what's going on within their school or within their school district to help advocate for additional resources, additional funding of athletic trainers. And a classic example, I talked about it during my talk, was the Middle School Achieves Project in Virginia, led by Shane Caswell at George Mason University, where the administrators forewent, what's the appropriate? I make up words. I'm a communication major and we make up words, but forewent their salaries. Someone can correct me on Twitter or whatever, shout out. Forewent their salaries to ensure that they could hire more athletic trainers into other schools and other sites. So injury surveillance doesn't have to be large scale. It can just happen within your own backyard, within your own community as well. And that's what I would advocate more so than anything else or choosing to participate with one program or not. Just making sure you're keeping track of data, making sure you're able to make that data worth it.
I know we're going to cover this a little bit in the afternoon, but I just wanted to relay a couple of questions kind of related. One, was there any information about the incidence rates of concussion in Rodeo? We saw, for those of you here yesterday, we saw a very interesting presentation on Rodeo. It looks like the incidence rate would be extremely high. And any information that's known about the incidence of CTE or dementia in these athletes? And then the final part of this question, does the CDC have any input on guidance for CTE?
I grew up in Calgary, Alberta, home to the world's largest rodeo. I know a rodeo when I see it, and in the Ivy League, there is not one. But in the data set that we've been collecting, data have been collected on 26 sports, and polo shows up in there, where there are horses. Close as we get in the Ivy League, the incidents, very few counts coming from polo. We don't have denominator information to know how much time is at risk. But no, we don't have polo, or we don't have any information touching on rodeo. But yesterday was a terrific talk on the incidence and broad range of injuries and management of that for rodeo.
There's a lot of sports we don't have information about, and we focus so much not only on what we know about, and those sports are the sports we know that have the largest populations. But when I talk to parents, particularly within the middle school study that John Register Mahak and I are working on, they keep pointing to one sport that they are really afraid of injuries of any sort, and that's figure skating. We think of figure skating as the creme de la creme of athleticism because we only see the professionals that are actually performing and competing at the Olympics, at the World Championships. And fun fact, I think many of you here know that Michigan houses a lot of the U.S. athletes and some of the international athletes as well. But when we think about figure skating at the youth level, we don't see all those falls, all those drops, all those lacerations and cuts that happen. And we really don't have a good sense of that, or can get a good sense of that to the rest of the research community, because there's just not being data collected on it. But we have many parents, I know, even in North Carolina, where you really don't think of ice hockey aside. Well, we have the Hurricanes, but I'm trying not to say anything mean about the Hurricanes. I was really sad this season. I had high hopes, but didn't happen. But there are a lot of needs for examinations of other sports other than the ones we've been studying so far. I think rugby, as far as rugby in the U.S., we only have one study coming from the Ohio State University, and I'm not sure if we have much more unless it's coming from international populations. So I think if you're clinicians and you're working with certain fields, I think it helps us as researchers for you to advocate for additional surveillance so that we know what are the areas of need, just as much as those parents have been coming to John and myself saying we need more research in certain sports such as figure skating.
So I think the last part of the question was about CTE and CDC, whether we have guidance. We don't do CTE work. Our congressional language focuses us specifically on TBI, and CTE is not TBI. Nevertheless, we did get some feedback from a number of groups that it would be beneficial to have some materials that summarize the science on CTE. And so we decided we would step into the hornet's nest that is CTE and put some materials out. One set of materials that's focused on the general public, parents in particular, and what we know about CTE, and then another that's focused towards clinicians and how they might counsel their patients, because we've certainly heard that many clinicians are getting questions about the risk of CTE, and so we wanted to provide some materials that might be helpful and so those are available on our website and might be beneficial to this audience as you may get questions about those as well.
I'd just like to make one comment regarding rugby. We just finished 2 studies on rugby. And in the United States, and to a degree in Canada, it's really been hiding behind football. To let you know, rugby is very dangerous in terms of head injury. Nobody wants to know that, especially the people in rugby. Both my kids have played competitive rugby. You're going to start seeing a lot more research, especially out of Europe, start to come out. In terms of the risks associated with head injury. The other thing is we published a paper in Equestrian, primarily the group out of Europe. They're very interested in equestrian. They're involved in a lot of equestrian events. And surprising to us, we thought coming off a horse at about 10 feet would be quite devastating. But because the surface is reasonably compliant and the angle they go in, we see a lot of concussions. So I thought we'd see a lot more traumatic injury, but we do see a lot of concussions in equestrian.
If I could just add briefly on rugby, many campuses have varsity rugby that may likely be staffed by athletic trainers and sports medicine. More campuses, I think, have club rugby, which in many instances is not covered. Those students may go to student health for their care. Often student health is not collected or connected to athletic medicine, so I think it's an undercounted issue, and it does need more attention, and I know that we'll be trying to give it.
And then the point I wanted to make is actually addresses earlier in the question where people were talking about unusual sports like rodeo or other things like that. I think about, like, we have big mountain skiers, snowboarders, rock climbers, rodeo, dirt bikes, skateboarding. And one of the things to remember in those sports is first of all that they have a risk for concussion, but they also have a risk for more severe traumatic brain injury. And so if you're returning somebody to like competitive skateboarding in like a half pipe or something, you shouldn't just be factoring in their risk of concussion. If they mess up, they have the risk to hit their head on a hard surface and have a more severe injury. Or if you have a patient who's coming, I've had this happen too, who's coming to you who's had a small subdural or a contusion, and they're in the concussion return to play protocol. Not always appropriate, right? Because they actually had some structural injury. You probably want to build in some additional buffer zone for them, or, and maybe have some visualization of what was the acute injury. There are some sports that by law, at least in California, for example, combat sports by law, you cannot be a licensed boxer or MMA participant if you've had intracranial blood. So those are important things. Somebody could look like they're recovering from a concussion, but if they had a non-operative subdural or non-operative epidural, you got to think about them a little bit different, and then also think about if they're going back to one of these sports that has risk for concussion and risk for more. You have to factor that into their return to play also.
So a number of helmet questions. I'll sort of summarize one of them. Kind of the question is, will translational impacts not result in concussion? And then the other part of the question on helmets is there a recommendation for manufacture and use of position-specific helmets?
I can answer the first one. I'm not sure what the second question is. To be clear, there's really no pure translational impact. So you're always going to get translational and rotation. What we try to do is try to understand the nature of the impact in terms of its dominance, rotational or linear. There is no question the association between concussion especially is with rotational. However, if you get impacted, any impact hard enough, you're going to have a risk for concussion.
And there is some look at position-specific helmets as well. The NFL is doing some great research. They're getting a great hearing and audience from the helmet manufacturers on some of the research they have. In quarterbacks, for one, they've identified hits to the back of the head. So is there need or necessity for additional padding at the back of the head? So there is that thought, and it wouldn't be surprised if at some point in time that we don't have position-specific helmets in football.
Just one more comment on that. A lot of the impact you see in football, and in some case hockey as well, is that you really are, the helmet is being overwhelmed. It's no longer actually useful. So in terms of whether you make a helmet slightly bigger, as they did a number of years ago in the NFL, the impacts that we're seeing in a lot of cases that are creating this risk or these injuries are really completely dominating the helmet. The helmet really stops working. And so if you're impacting at these high energies, there's not much a helmet's going to do, no matter if it's a little bit bigger or a little bit different. When you test it, it shows that it performs a little bit better, so that's good. You want to have better helmets all the time. And you want the manufacturers working on better technologies, no question. But to suggest that it's going to be the answer to these high energy impacts is it's not going to happen.
And I think sort of a follow-up question on that of age-specific or competition-specific helmets. I know the testing is pretty standard, and you can certainly build a very heavy helmet, and you put that on an 8-year-old, that can create its own set of problems.
Yeah, I mean, for sure, there's a couple things when you think of age-specific helmets. Number one, that we think is most important, is that it's the way these children are getting injured. And it's different. As I was saying in my presentation, kids who play Pop Warner football are playing a different game. You don't see the game at all. In fact, a lot of my researchers don't want to watch a lot of that video, primarily because it's boring as hell. Nothing is happening, which is good. And it's the same in hockey. They're trying their absolute best not to hurt themselves. And that changes as the game changes, of course, and you get elder. So when we start looking at helmets that's age-specific, I think the first opportunity is looking at the mechanism of injury. If they're falling and hitting their heads on the ice, like we see in youth hockey or age group hockey, or in football slightly different, then you can design a helmet that will help protect them. And the good thing about really young kids playing sport is, number one, they're doing their absolute best not to hurt themselves. That's a priority for them, thankfully. And number two, the energy levels they're dealing with is way lower. They're shorter, they don't drop as fall, and they don't run as fast. And their skill set in terms of creating these high energy impacts is a lot lower. So yes, age group helmets would be a benefit, no question.
Thanks
So,
for that.
and I went to the ASTM meeting last year, and one of the things, there's the common sense part of it, which is that you would want, a helmet designed for the type of injury and also for, the supporting neck musculature and other things like that. That's common sense. But I think, at least in the US, right, helmet certification is based on a sort of a single standard that has to be changed as a matter of public policy before the helmet manufacturers will actually take the quote-unquote risk of designing these helmets. And so I think that's where we're stuck with, is that everybody can see the common sense that to do something that's age appropriate, but there's sort of a policy and regulation roadblock that right now prevents that from happening.
Yeah, I mean, as a manufacturer, which I was at one time, the last thing you want is a court case where a kid, a young athlete who had unfortunately suffered an injury, head injury, and you say, well, your helmets that you designed for this 8-year-old or 7-year-old doesn't manage the same amount of energy as the one you're designing for a 25-year-old. Why? So that becomes challenging, and it's absolutely correct. Right now, we have one standard, and that standard is very useful for manufacturers. To change that standard would require a great deal of effort in terms of public policy.
I want to thank the panelists, both for the panel session and for the morning session, which I thought was unbelievably great. Thank you very much.